Hello, YouTube. So we are live on Instagram and YouTube, but I'll be sharing like everything on YouTube. So sharing my screen on YouTube. Yeah, thank you very much. Love the thumbs up. And very exciting evening for me to be here with you. So good. That way we can be all together, no matter where you are, what you are doing, if you are in another country. So it's so good to have you here. So is everybody from Instagram moving to YouTube now? So I'll leave the Instagram and I will just go and let me see on YouTube. We are live here. So what we are going to do, let me check if you have any trouble joining YouTube from Instagram, just leave a message and we'll just guide you through. But the link is on my bio and we'll be sharing a screen. So I'll just share the screen now and let me know on YouTube if you are having any trouble. Just 1 second. Is it all right? Can you hear me and see me? Black screen? Let me see. Wait a minute because there is a delay. It's okay now? Yes, finally. Yes, now. Thank you so much for your patience. Yeah, it means a lot. So thank you. So welcome, everyone. And let's start over. Just can you carry on and see if you are still seeing me? So, right, people from Instagram, move to YouTube, please. There is a link on my bio, and if you can see me there, because I'll be sharing the screen. And finally, the launch of my new book after some technical issues. So I'm very happy that everything is working fine. Confirm to me on YouTube if you can hear me. People from Instagram, move to YouTube now. Click on the link. Thank you very much. I'll leave it on, but I'll be sharing the screen. So welcome, everyone. So it's with a great happiness that I come to you and say that the book is now officially launched. And after years of clinical practice, research, and methods I developed to help ourselves to diagnose the endodontic pain or the dental pain. So one thing that I need to say is that I'm very honored to have Julian Weber writing the foreword of my book. So thank you so much, Julian. Can you please confirm you're still hearing me all right and seeing the screen? Thumbs up? Brilliant. So tonight, the plan is to go behind the scenes insights and practical tips from the book, details about the book, and how to secure your copy. And the question now is why endodontic diagnosis is the foundation of everything. And it is, isn't it? So if you are uncertain when you are diagnosing your cases, if your patients, they have vague pain, radiographs that look fine, but in reality they are not because you've done the treatment, you've checked the radiograph, everything is fine, but the patient still feels pain, still has some pain, and you don't know exactly where it comes from, if there is any problem with your treatment, if you are performing your tests and you are having some conflicting test results, this book is definitely for you. So when I wrote this book, the main purpose to write this book was to give clarity, confidence, and precision when we are doing the endodontic diagnosis, because that's the main thing. I've got the referral practice, so we have 2 referral endodontic center, one in Portsmouth and one in Southampton, and we receive daily referring letters from referring dentists, letters saying that the patient, they can't understand where the pain comes from. And that's exactly why I wrote this book. But before we dive into the book, I want to know where you are joining us from. So where in the world are you? Please text in the box over there and let me know where you are. So I can see people from England and I can see people from Brazil. So wonderful. Any other? Oh, São Paulo, very good. UK, amazing, amazing. Thank you very much. England, Windsor. Oh, I love Windsor. But no matter where in the world you are, we always struggle when we have patients with pain. Sometimes there are so many vague symptoms that we don't understand what's going on. So there are some missing details that can lead us to the wrong diagnosis and even to the wrong treatment. So that is what we need to avoid. So this case, for example, so again, people from Instagram, you won't be able to see that. So move on to YouTube and then we can see the screen. So in this case, the dentist performed the root canal treatment and even the retreatment. You can see on the first attempt, there was like a separated file, and then the second attempt, a little bit of extrusion of the GP. But still, that large periradicular radiolucency still presents with the same sort of size. And the dentist didn't know exactly what was going on and referred for endodontic microsurgery. So let's have a look in what we created in the book, which we developed a structured framework that calls diagnostic triad. So it combines the data collection, clinical examination, and the radiographic interpretation in any order. And you can go back and forth, and you have to use all three elements. And I'll explain you why. So in this case, we've got the radiographic interpretation that we saw the size of the lesion, the extruded GP, the separated file, but still, it's just a 2D image. We don't know what's going on. And we have the data collection. We have DAO, that's the patient saying DAO, constant ache, and it gets worse when I bite on this tooth. It feels really strange when I chew, almost like this tooth is a bit loose. What is then missing? The clinical examination. So what have I got here? I've got a tooth, the lingual aspect of this lower right one has some gingiva and bone loss. So it's quite a recession over there with a deep periodontal pocket. And also on occlusal view and checking the occlusion, I can see that the incisal edge is moved forward. So you have that not aligned. And the first thing you think about is, was there any trauma to that tooth? But you talk to the patient doesn't recall any trauma at all. But there is something else that has in this patient, and is a tongue piercing. So when you see that, you need to go back to the data collection and try to have another conversation with the patient, because the patient won't come to your practice and say, hey, doc, I've got a tongue piercing and I'm moving against of my tooth, and my tooth now is moving, lost the periodontal support, and now I've got that infection. So the patient doesn't know any of that. He only knows that he wanted a tongue piercing. So it's up to you to know exactly what's going on and talk to your patient about that. So that's exactly what was going on. So the patient was moving. So no matter what you do on that tooth, the treatment will still fail because of that trauma. So it's important for you to understand that the diagnostic triad is a structured, grounded framework that for you not to miss any detail and for you to stop guessing, because the problem with guessing is that you can lead to a wrong treatment. And I don't know if you've been there, but it's not a good feeling. We receive letters with treatment that was in the wrong tooth, and that's not a good feeling at all for the dentist who performed that, for the patient. So please, if I can tell you what to take it from this lecture tonight, is never diagnose based in one leg of the diagnostic triad. So you need all three elements. You have to combine them. But imagine you are getting all the information, so from your data collection, your clinical examination, your radiographs, but you still don't know what's going on. You still think that there is a missing piece and you don't know what to do next. That's the other method that I developed in this book, and it calls the real pain method. So the real pain method is another structured framework for you to follow to get a more precise idea of the pain. So basically, it's a dental focused framework. There are others in the market, like you can find it, but it's more like for medical purpose. This one is a dental focused framework. It's structured, it's predictable, very easy for you to communicate with your patient and for you to identify the red flags and recognize the patterns, evaluate pain systematically, transform vague complaints in real clues. And how does it work? It's an acronym with letters, so REALPAIN. Each letter means something, and each letter meaning has its own question. So, for example, R is the region, so you should ask open-ended questions, not questions like yes or no, because with yes or no questions, you cannot interpret anything. So where exactly is the pain? The E, for example, episode pattern, how did the pain start and progress? So when you do that, what you know from textbooks, you've got like some codes that you learn. Localized, diffuse, that's for the region, intermittent, continuous. However, what you need to understand is that the patients, they don't know that. They don't follow textbooks. So they don't come to you and say, listen, I've got like a, uh, anyway, like an intermittent pain. No, they won't say that. They will use their own words. So when you ask those questions in a certain order, and you understand the pattern of the pain, you need to decode what your patient is saying so you can get that information. So, for example, if I've got a tooth like that, like I've got the upper right canine and upper right premolar, and they are touched in the bridge, and the patient comes in pain and point to that area interdentally, more apically, and say, this is where the pain is coming from. So in your eyes, when you check the x-ray, you can think about, well, the root canal treatment is not so ideal in the canine, so it may have something here, it may have something there, but you don't know. You go to your clinical examinations, you perform some tests, but because it's attached to the bridge, no matter what you do, it just like radiates to one another, so you cannot understand where the pain comes from. But when you follow that structure, the real pain method, at least you can understand what's going on to that tooth. What's the pulpal diagnosis that could be? Well, if it's the canine, is the previously treated, initiated therapy. If it's the premolar, it could be a necrotic pulp, irreversible pulpitis. But there is pain when you do like a palpation. So, we are in a symptomatic apical periodontitis. So you are going the right direction, but there are other things that you need to do to really make sure which tooth you are treating, because you may treat the wrong one. So that's when you think about what to do next. What's the missing piece? What do I need to do? And then you go to the CBCT, for example, so you can understand where the problem is coming from. And if you look now with your trained eyes, you can see that the lamina dura is going really well and continuously around of the apical portion of that canine, and not as much as the premolar. And that is confirmed with the image. But another thing that you need to think about is that that patient is a person with fears and with problems with trust. They have like backgrounds. They don't know, you don't know what happened in the past in the dental chair with other dentists. So that patient will accumulate experiences and come to you, and it's up to you to establish an effective rapport so you can get that information you need from your patient. And we are going to talk about that in the book. In the book, we have 3 chapters. The first one is the data collection. So we talk about report, we talk about how to talk to your patient, we talk about the diagnostic triad, the real pain method. The second chapter, we go on the clinical examination, we go on extraoral examination, we go thoroughly into that. Intraoral examination, we explore all the possible intraoral examinations you can perform. We go through the magnification as well, because that is very important. So write in the chat who has magnification and is wearing magnification, not participating. So have you got any magnification in the practice? Just put in the chat on YouTube so I can see what you are, if you are answering that. Yes. Can I do RCT for a tooth with recession? We go through questions at the end, but yes, you can do it. Depends on which kind of recession you are talking about. If it's a communication, like go to the apex and things like that. But you can perform. There is a combination of endoperioral treatment that you can perform. But we go through at the end, if you don't mind. So magnification, we'll talk about different magnifications, a 2.5, a 3.5, 4.8, 6, microscopes. It all depends on which part of your career and which stage of your career you are and what you are doing. If you are doing more endodontics, if you're doing general dentistry, if you need to see the full arch, or if you are just doing one tooth. So that is all explored in the book as well, so you can choose your magnification. We'll go through cracks and resorption. That's a very important topic. Nowadays, we save more teeth than we send for extractions, even if they are cracked. It all depends where the crack is and how committed your patient is. Resorption is the same thing. It's all about where the resorption is, so we can save the tooth. And another case that I always receive, when I put that on my lectures, there is always like the majority of the class putting the hands up and saying that this tooth needs to be extracted. And if we were showing that case probably 10, 15 years ago, I would have said, yes, it looks like, because we all learn about J-shaped lesions and big lesions. Everybody fears the big lesions. But what you need to understand is that the patient has swelling. Yes, it has swelling, but does it have a deep pocket? Does it have periodontally compromised? Is it like this tooth compromised periodontically? That's what you need to check. And the CBCT is there for you. So in the book, the third chapter is all about image. So we'll be talking about when to use CBCT and why to use it. If you don't have the CBCT, you can take like the normal radiograph, but you need to kind of position your cone so you can take like in an angle. So we'll talk about that, the cone shift technique, in the book as well. But of course, if you have the CBCT, it's much better. For this case, for example, we could only see that cortical, very thin cortical bone and the amount of bone in the furcation. So we could, like on the CBCT, so we could plan the root canal treatment. And yes, that tooth could be saved, and that J-shaped lesion that we thought is not a J-shaped lesion, was just a lateral canal here, just causing that whole problem and the bone loss. And once that tooth is treated, then everything heals nicely. Wow, removing coronal restoration prior to the treatment or not? I think this is the most common question I have in my lectures. And I think you make your own decision after seeing this article here from Abbott. I absolutely love this study. And he compares the tooth prior to removal of the restoration and after the restoration removal. So prior to it, they could see 19.2% of caries, 23.2% of cracks, and 39.2% of marginal leakage. But after the restoration removal, the numbers are so high. And look at that, 86.1% caries were now found, and 60% of cracks, 99.6% of marginal leakage. So almost 100% marginal leakage. So yes, you have to remove the restoration. If you can't, or that is fine, but there is always a compromise. So if I could say, please remove the restoration, either the day you are doing the root canal treatment, or like, of course, change that afterwards. But for you to really see the crack, that's the best thing to do. So the summary of tonight is you need to use all three elements in any order you need for the diagnostic triad, and use the real pain method as you need as well. All the questions, and look out for some clues, perhaps not the same codes that you've learned, but some clues that you can identify to those codes. So, and limitations of radiographs, you will find as well in the book, and that's what we discussed about the CBCT, the normal X-ray, conventional X-ray. Sometimes you cannot see. And that's just a sneak peek of the tooth, or the book, and you can see the link over there. So if you want to purchase the book, it's available on Amazon. So well is available on Amazon. Not yet in Brazil, but it will be. So I'm in Brazil in a couple of weeks, launching the book at Unesp, at the university, and I'll be talking there. And as soon as we finish, probably next year, will be available in Brazil. Right. So now we are opening for questions. So let me know. I will just screen here so I can see. Oh, hello, Maria. Is it Maria? You're from São Paulo too. Very good. Good to see you here. Thank you very much. So questions, everyone, about the real pain methods, diagnostic triad. If you are having problems, tell me here if you are having issues diagnosing pain. It's a bit delayed here. Magnification, I can see some 3.5 to 5.5 magnification. That's very good. So I normally say that anything over 3.5 is good for when you are like doing a crown prep, or if you are doing root canals. Ideally, root canals, I would say for microscope is better if you can afford a microscope, but or a 6. But yeah, 3.5, 5.5 is really good. Hi, Jonathan. Lovely to see you here. Yeah, it will be a lot. It will be available. So don't worry at all. Yeah, that's fine. No worries. But lovely to see you here. Come on, guys. Come with some questions. I can see people from Southampton. Birigui. Very good. So if you are a dentist in the UK and you want to celebrate with us on the 14th of November, we are celebrating at the Spinnaker Tower in Portsmouth. So if you want to participate in that event, please send a message on the chat and we can get the information through to you. And thank you so much for staying with us. So if you want to purchase the book, the link will be available probably in the chat as well. So if you have any question, just drop and we'll get your question answered. But thank you very much for staying with us on Instagram and YouTube, and we'll be probably making that live available very soon. Thank you. Have a good evening, everyone.